and the Social Security Act in 1935. And then with FDR's later proposed Economic Bill of Rights, also that sometimes called the Second Bill of Rights, in which he outlined healthcare as a right. He died before he could, before that proposed Bill of Rights could be ratified. But these same principles, the idea that healthcare is a human right, were adopted in the UN Universal Declaration of Human Rights after World War II, to which the United States was a signatory, like all of the other UN members. So, history would support your sense that the United States has already sort of made a position clear, staked a position on this historically. And history would also support your idea that it just has not met the potential, it hasn't realized that claim. Virtually every industrialized nation has implemented some type of universal health coverage that protects these rights, with one notable exception, and that is the United States. So I'll leave it there, as that's that historical grounding for what the United States has committed to. It's not a right that's guaranteed in the Constitution of the United States, though it is in the constitutions of over 70 other countries and globally. But it is part of the UN Declaration of Human Rights that the United States was party to.
Thanks, and I'll jump in as a physician. I absolutely believe that healthcare should be and has been fought for as a human right in the US, and going even further back than FDR, thinking with the freeing of enslaved people in the United States, one of the very first things that was focused on by the Freedmen's Bureau was establishing healthcare for newly freed slaves, and knowing that they were coming from a place of inequitable health access and really not being integrated into the healthcare system, and needing to meet those health needs was a national, a necessity for just the ability for people to live out their best lives and live out the fulfillment of their lives. So with health being fundamental for, really reaching our potential as humans, then healthcare naturally comes along with that. So in any country, I imagine it's in our interests for all the citizens to reach their maximum potential. And then with that, fundamental needs have to be met, and that's where health and healthcare get tied in. So of course, there's been a conflict with that, because we're also a nation that values markets and finances, which often runs against kind of universality of healthcare. But I think when we're looking at the humanity of our citizens, it's really hard not to try to advocate for healthcare to be a right for folks.
Yeah, and I'll just, I would go back also in the Declaration of Independence. We talk about the pursuit of life, liberty, pursuit of happiness as certain protected, creator endowed, unalienable rights. And, the framework of the country at that time and what our roots were fighting for those pursuits. And, you see it borne out all the way through the course of our history, where, in the late 1700s, the federal government established hospitals to take care of injured seamen who were the merchant marines of the time, and so much cargo and freight was shipped in, and that was really the economic bedrock at that time of the country. And so they recognized the importance of being able to help, in that industry, make sure that they were healed, that they were taken care of, and then you play that out through, the course of the country's history. Amy mentioned the policies of FDR and the New Deal, and you take that through the Great Society and the creation of Medicare and Medicaid, and even into the 1980s, where Congress passed the Emergency Medical Treatment Act, EMTALA, which requires hospitals who accept Medicare to take care of any patient in an emergency room setting, regardless of their ability to pay. And you've got to render care, you've got to provide services. So the idea that, that healthcare is a right, I think goes all the way back to the Declaration. And we've seen it played out over the course of our country's history. When I taught classes at UMMC and doctoral and master's level health administration classes and taught the class on public policy and healthcare policy, that was one of the questions in our textbook that we presented to the students. And I'll tell you, most of the students, when asked that question, agreed that healthcare is really a right. And I think the legislative history of our country bears that out as well.
But as Dr. Collier, I think, was the one that mentioned, there seems to be a sort of a push and pull, sort of a free market versus governmental role. How do you rectify that or compensate for that? And why is it there's still so much controversy whenever involved in the healthcare system when you try to make changes to move towards making that right more of a realistic goal for the country?
It's expensive. That's why, because healthcare is really expensive, especially here in the U.S. So there's a lot of cost that goes into it, and there's a lot of money to be made, and so the stakes are really high in that regard. And so it creates a kind of natural conflict where you're running up against, the industry that drives innovation and the industry that drives, creating a lot of the abundance we have in healthcare, but it hasn't been paying off in terms of health. In the United States, we spend the most by far and away compared to other nations, and we don't see the health benefits because we certainly don't rank highest in terms of health in our country. So it certainly is a conflict, and that conflict is evident in the fact that we have cutting edge, technology and services available in the US, but we also lag behind in some really basic aspects of healthcare and health, really, and the health being just, general wellness, mental health, the not just the absence of disease, but prevention as well. And so the conflict is really evident, I think, in what we see in the US, which is huge disparities between haves and have-nots, and the ability to do amazing things technologically and advancements in medicine, but all of those things are not shared equitably, and so it is a real struggle.
Yeah, and, I think when you think about healthcare and you think about the economics of capitalism and supply and demand, and things that we pay the most for and the things that we value the most. I mean, pretty much every one of us would value our own health. That would rank pretty highly. Probably what would rank even higher than our own health is the health of the loved ones around us. What we would pay for our children if they became sick, or even our parents. And so there's a tremendous demand on that. And typically where you're seeing a high demand, you're going to see higher costs. But, one of the things that we've seen in Mississippi, particularly with our hospitals, is our hospitals have among the lowest expenses per diem, per day expenses than for inpatient admissions and such than any other hospitals in the country. Our nonprofit hospitals actually have the lowest inpatient per diem expenses in the country. Our community and state-run hospitals have the 8th lowest, and our for-profit hospitals in Mississippi have the 12th lowest. So in Mississippi, our cost per day, they're doing more with less than they are in other places in the country. And, the need is great. The supply of physicians, it's a short supply of physicians. We're one of the physician deserts, I guess you could say, ratio wise. And technology is expensive, infrastructure is expensive, and the rules and regulations, particularly for hospitals, that they have to comply with to operate their facilities. Everything from their HVAC has to be done a certain way, and filtration requirements and all that. It's expensive to be in the healthcare business. And then of course the cost of labor as well. And, when you've got young professionals coming out of nursing school or medical school with a significant amount of student loan debt, it has to command a certain salary for them to be able to pay that debt off, because it is significant. So a lot of things that go into that when you talk about it from a market perspective.
Yeah, in a state like Mississippi, I mean, where would the healthcare system be without a governmental role?
When you look at, just speaking from the hospital perspective, typically our average payer mix across the state with all of our hospitals, it's about roughly 40 to 45% of the payments come from Medicare. Roughly 20% comes from Medicaid. So, 60-65% of all the payments come from Medicare or Medicaid. You throw in another 3% for TRICARE, which is military healthcare benefits. Now you're pushing 65 to 70%. About 12 to 15% of the patients that are being seen come with zero insurance. They're uninsured. So now that's about, now you're pushing 75 to 80% is the range across the state. So from the hospital's perspective, you're only looking at, a very small amount that is, commercial insurance. So the government role, when you factor in TRICARE, Medicare, Medicaid, in Mississippi, it's significant. It's a significant amount. Medicaid itself, I think the last numbers I saw is probably about $1.6 to $1.7 billion a year paid just to hospitals. The total expenses for the Medicaid agency have been running over $6 billion pretty consistently for the last several years. So that not all of that's coming to healthcare providers. Some of it goes to some of their contractors and the cost of running the agency. But the cost, just the impact of those dollars in Mississippi is significant.
Dr. Collier, you have any thoughts on that?
Yeah, I mean, I'm an OBGYN, and so 65% of births in Mississippi are covered, or maybe a little bit more now, are covered by Medicaid. So babies are born under Medicaid for the most part in Mississippi, and these are working moms. They're, the patients I care for are predominantly on Medicaid, and all of them are working mothers, and that is the type of jobs that they can obtain don't cover health insurance, and so they don't have health care before they get pregnant, or they don't have easy access to it, and it's when they become pregnant that they get covered. And we do our best to provide great care for the duration of the pregnancy, and unfortunately only 6 weeks postpartum, and then they're back to not having insurance again. So absolutely, right now the pregnancy care we have would not exist without Medicaid and government's involvement. And we are, again, even with the expenditures we have within the system, they are covering employed people. So it's, one could say it's a discount to those employers in a sense, because then they don't have to cover those costs. But, we have the highest preterm birth rates in the country. We have the highest infant mortality rates in the country. We have among the highest maternal mortality rates. And so the way we're covering healthcare isn't necessarily producing the best outcomes. It's only part of it, health insurance. But and then even thinking back, you're asking, where would healthcare be? As of 1964, it was legal to discriminate. We had segregated hospitals. It required legal action to desegregate hospitals under Civil Rights Act, and Mississippi had even as of 1966, still 40% of hospitals or more were still segregated. So that required government intervention to really begin the process of creating equitable care, because that certainly wasn't existing here. So when we think about certain populations without the government involved, there'd be, more than a two-tiered system where, we were seeing inequitable care. And so we're trying to achieve that goal of everyone having access to the best possible healthcare system, but that's still in the works.
You brought up an aspect of government's role in healthcare that I wasn't even thinking of when we're talking about doing this program. But yeah, I mean, I remember, I'm old enough to remember when hospitals were segregated, and we hear so much about the schools, but I mean, that was another issue that where government played a pivotal role in dealing with it. Richard, we got a question from the listeners wanting, how do we compare with other states in terms of the percentage that comes from Medicaid payments compared to others? Can you answer that question compared to other states? I would imagine we would be the highest. That our hospital is more dependent on Medicaid just because of our population than many other states.
We are, we're more dependent on Medicaid, even though, I mean, as a percent of our population right now, we've got about 750, 760,000 Medicaid and CHIP members. And you've got, 3 million people in the state of Mississippi. So as a percentage of our population, it's a pretty high percentage. And over half of that, obviously, are kids. As a percentage of our population overall that's on Medicare and Medicaid, we're above average. We're not right at the top. There's some other larger states with actually a larger percentage, but most of those other larger states also have a higher percentage of commercial. And one of the reasons that that we're maybe a little bit artificially low is because our uninsured rate remains so high. If we did Medicaid expansion, then we'd obviously have more people on Medicaid, but you would reduce that uninsured amount. And then when I looked at this, I guess about a year or so ago, if we expanded Medicaid and put our, cut our uninsured rates way down, then we would be top 5 highest percentage of Medicare and Medicaid in the country. But the reason why we're not is because we're just holding on to a significant chunk of our population that's not being allowed to get on Medicaid.
Yeah, I've been holding back on turning to Medicaid expansion
I
because
probably teed that up too soon. I'm sorry.
I knew it would dominate a lot of the program. But since you brought it up, let's talk about that. Before we talk about it, I think there's a lot of misunderstandings about Medicaid, and that in Mississippi, in most instances, if you are an adult and are able-bodied, don't have any, not on disability, not pregnant, as Dr. Collier mentioned, or I mean, you don't have health care. I mean, you have access to health care if you get real sick by going to the hospital, to the emergency room. But other than that, you don't have any health care coverage. You're just kind of out there with nothing. And as Dr. Collier mentioned, a lot of the people who would be impacted by Medicaid expansion are working people who work at jobs where their insurance, their jobs just don't provide insurance, and they don't make enough money to be able to afford insurance. So Medicaid expansion would fill that void, and I think 38 states have expanded Medicaid to take Medicaid expansion under the federal legislation, ACA. Some people call it Obamacare, but Mississippi, for various reasons, has not. Can anybody want to jump in and talk about that? If not, I got some specific questions I can ask, but feel free to just jump in. I think y'all can do a better job of talking about it than without my questions.
Well, I'll go ahead and jump in. Yeah, so, the reasons why we haven't taken expansion, primarily, or at least originally, were based on the notion that we couldn't afford it, and the concerns that, what would happen when the federal share was decreased from 100% down to 90%. And after, a period of years, the federal match rate went from 100% after the first 3 years down to 95%, and so on, down to 90%. And so the concern from the state's perspective was, we struggle to fund the program we have now. How can we afford to fund another $100 million or so in the additional state share cost? Well, What's happened recently is, in an effort to get more of the non-expansion states on board, the federal government just passed the American Rescue Plan, and that's going to provide an additional 5% federal match on top of the match that we get now for our traditional program. So the money from that equals about $300 million a year for 2 years. So total of $600 million. The cost of expansion is still 90% federal, 10% state. That's not affected by that 5%. That's just sitting over here on the side. So, you know, if you're up 300 million on your traditional program, but it costs you 100 million to expand in order to get that 300 million, you're still 200 million to the good. And that's before you even take into account what $1 billion turning over in your state's economy does. We've estimated a minimum $100 million in new revenue generated from that. We've actually, one economic report shows an additional 200 million in dynamic state revenue. And that comes from a combination of just plain old tax dollars circulating in when you have $1 billion pumped into the economy. But what it also does is, for a lot of these low income working adults, when they're getting the health care in the proper delivery manner, they stay healthier. They're able to work more. They're able, many of them are hourly workers. Well, if they don't show up for work, they don't get paid. And so by keeping them healthy and accessing healthcare in the appropriate way, because they've now got coverage, then they're more productive workers. They're earning more. That generates more income tax for the state and more spending availability for them. And so it's just a huge rip. I mean, it's like it's not throwing a pebble into the pond. It's like throwing a meteor into the pond. It's that big of an impact on the state's economy. It's the biggest single thing that we can do for healthcare. It's the biggest single thing that we can do for Mississippi's economy. I mean, it's the equivalent of a Nissan plant, a Toyota plant all over the state. So, you know, and we would, any other opportunity to generate that type of economic income for the state, we would have a special session tomorrow. We might even consider having a special session on a Sunday morning to get that done. But that's
It'd
not
be a religious experience.
Yeah, so it ought to be. It ought to be. Yeah. So that's, you know, that's where we are. But it would, we think, very conservatively cover another 200,000 able-bodied, working, low-income Mississippians. That's what this is for. It's like CHIP, all the great things that CHIP has done in keeping kids healthy and having them with access to care. It would do very similar things for adults.
Yeah, Senator Hobb Bryan is fond to tell him his legislative colleagues that these people would be covered, actually work a lot harder than the legislators do. But I'm not asking you to comment on that.
We have some very hardworking legislators.
And we can talk more about that. But Dr. Forbes, I want to bring you in real quick from a historical standpoint. There's been so much controversy about the ACA, about Medicaid expansion. And just looking from a historical standpoint, you referenced some of these things that's happened throughout history, through the New Deal in the 60s with the war on poverty, when the Medicaid program was, the original Medicaid program was enacted. Has there always been this much controversy about these type of sort of the evolution of the healthcare system to kind of, I guess you could argue, all these things, some people would argue, has moved the healthcare system in not a perfect way, but in a better way toward providing coverage to more people? Has there always been so much controversy involving those efforts?
The short answer is yes. There has been in the United States. And just to situate this in context, you know, the US is the only wealthy country without universal access guaranteed by the government. But countries with universal healthcare access have a variety of systems ranging from 100% government controlled, like exists in Spain and the UK, for example, to private insurers that are regulated by the government, as exists in Switzerland, for example. But what all of them have in common is 100% coverage of their citizens. 100% of their citizens are covered. And the US still has over 30 million people without health insurance. And as Dr. Collier alluded to, and these uninsured are not evenly distributed across the population. And so we see a disproportionate number of poor people, a disproportionate number of people of color, African Americans, and we know this. But the US system has always been a mix of public and private programs. One of the questions that I often get is, well, why do we stay with this market system if it's not serving us? If the costs are so high, if there are other examples out there that serve people well. And I think history can shed some light on that. As I mentioned, the earliest efforts at universal care were in the Northeast, and they really had to do with coverage for missed labor, missed wages. People were concerned in a post-industrial society, what happens if your labor force is sick, you can't have a strong economy. And so the first plan that was put out, the first early plans in the late 19 teens and the early 20s for any kind of a universal healthcare coverage were based on the German model. And the United States had just defeated Germany in a war, in a global war, and was not eager to bring any kind of an authoritarian program into the United States. And the timing of these 1920s programs matter also because the other thing that happened in that same period was the rise of the Bolsheviks, the Russian Revolution. And so people began to equate any kind of universal coverage with communism. This is the first time that we get that kind of ideological opposition to any kind of a universal coverage. And these are the same arguments that gained sway and really became argued vociferously after World War II, during the Red Scare, and in the wake of another German defeat, another encounter with Germany. So the reasons why these efforts that were meant to alleviate fear around health and illness and sickness and surviving, the reasons why they failed was because the solutions contained other fears that Americans had. The emphasis on the dangers of socialism and the un-American nature of other countries' health systems have been echoing now for a century. These early ideological oppositional factors have been a part in sustaining our market system, our medical market, even with all the problems outlined here. Despite all of these, there are ideological roots for this, and I think it would be probably helpful to think about how much government involvement there has actually been in healthcare from the beginning. Government involvement in healthcare goes back to the colonial period. Our U.S. healthcare system has always been a mix of public and private programs. Town and city governments were responsible for medical care for the poor, and they built hospitals, they built almshouses. This was different in slave states in the South. There was variable medical care, usually inferior medical care, not always, but nearly always inferior medical care, always separate. Private medicine and hospitals coexisted alongside public ones. Starting in the 18th century, most US hospitals were a combination of both public and private. And in the 19th century, the other income stream for hospitals was that hospitals began to charge fees to patients. Most hospitals today are a mix of public and private, and what Dr. Roberson is talking about and what Dr. Collier is talking about, bears this out, that we see even the hospitals that we would call private hospitals actually get a substantial amount of their income are funded through revenues through Medicare. And then in the early 20th century, new programs were created, separate federal government dedicated programs to veteran affairs and to Native Americans. And so these were absolutely government created, federally government created and federally funded from the early 20th century. And at the same time, in the progressive era, there were, excuse me, there were enormous efforts to create political victories for universal health care. Again, in the New Deal that we've already talked about, and we can come back to later. Both FDR and Truman tried and failed to get these victories for universal care, but anti-market arguments were out there, and I think that's the government has been involved in U.S. healthcare systems from the beginning. And then in the 1950s, so just before Medicare and Medicaid that we've been talking about, after these failures of Truman and FDR to advance a universal system and to include healthcare in the Social Security Act, people sort of drew back. And it was in this period in the 1950s that Blue Cross and other private insurance companies were created instead. And I think this is the important point for us to see in the creation of Medicare and Medicaid, where the impetus came from here. Private insurance through employment grew to be the largest part of U.S. health coverage in the 1950s. Private insurance through employment was the biggest part of U.S. healthcare. But government was involved even in these private enterprises, these privately driven enterprises. After World War II, in order to stabilize the economy, the US federal government instituted wage freezes, wage caps. And this meant that employers couldn't attract employees in this country through paying them more. So instead, they began to offer them insurance packages. So here we'll pay you for these. But even these private insurance packages were shot through with federal laws after World War II that provided tax subsidies for the employers who gave the very benefits that we're talking about. So Medicare and Medicaid, which were created in 1965 as part of the Great Society, were created because the private system that really came into its own in the 1950s had failed to cover large groups of people because this insurance system was implemented through employers. So if you didn't have an employer, if you weren't employed, if you had a disability, if you were retired, or if you were just simply underemployed and too poor, you weren't covered here. And so that was the impetus to step in and fill the gaps that were created by this private system. But it's important to see even that Medicare and Medicaid share a lot of characteristics with the private system. Medicare has deductibles and they have limitations on coverage. Their eligibility is controlled by states, as Dr. Roberson was talking about. And you mentioned the last big expansion of health coverage, the Affordable Care Act. It's also a public-private program. So again, an intertwining, it provides federal subsidies to private health insurance companies in exchange for them to agree to treat people who have pre-existing conditions. So the bottom line, I think that's important to lend context to this discussion is that there's always been a mix of public and private funded healthcare in our healthcare system. So government has stepped up when the private sector has failed to care for essentially the least profitable segments of the population.
Yeah, you brought up some points that made me think. I had to bite my lip every now and then when talking to some of my older friends who complain about ACA and Medicaid expansion and government taking over healthcare. And then the next breath, they're talking about using their Medicare to go to to have all these expensive medical tests done. And I just think, what do you think Medicare is, except for a government program? But Dr. Collier, bring you back in. I'm going to kind of ask you a personal question, if you don't mind. As the only doctor on the panel, physician on the panel, do you get frustrated sometimes seeing the sort of the inadequacies in our system, and what do you think about those, and what would you any advice you'd offer or anything? We're all ears.
Yeah, absolutely. It is a point of frustration. It's something that you don't learn a lot about in medical school. It's like taboo to think about money when you're pursuing becoming a physician. So it's very separate. But once you become a physician, you learn how much politics and money have to do with healthcare and what you're able to do as a physician, what you're able to offer, who you're able to offer it to. I think one of the most frustrating, especially recent issues, is when I'm caring for someone in pregnancy with a medical condition that we identify and manage very successfully while she's pregnant, and then she loses her health care at 6 weeks postpartum when there's no medical cutoff, where all of a sudden all complications related to pregnancy disappear at 6 weeks postpartum. That was a very arbitrary cutoff. For insurance coverage, and then really our hands are tied about doing more. So I chair the maternal mortality review committee for the state of Mississippi, and I review maternal deaths, and most of our deaths are preventable, and most occur in the postpartum period, and not all are among women on Medicaid, but many are. And many of the things they're dying from are minor preventable things like high blood pressure, heart disease, suicide, depression, drug overdose. And these are among people whose conditions were well managed and were cared for. And then that care gets cut off. And so when we look at maternal deaths, we decide if they are preventable or not. And oftentimes we're focused on the specific clinical care. But I think for the state of Mississippi, we have to we have to look at the contributing factors beyond what happens within hospital walls and look at the policies that are driving the health conditions we see. So I can just as much say this mom's death was preventable because she didn't get the medication she needed, but I can also say it was preventable because we have policies that are not in place that could have helped keep her safe. And so it is absolutely frustrating because we at one side profess to want to reduce things like infant mortality. I mentioned we have the highest preterm birth rate in the country and the highest infant mortality rate. More babies die here per birth than any place in the United States of America. And that should outrage people and want us to do more, to do whatever it takes to prevent that. And then it doesn't happen because a line is sort of drawn when it comes to expanding Medicaid. And I think another very uniquely, American thing is how there's a sort of deservedness on who gets to benefit from these type of policies, and I find that there's a level of resentment towards the fact that this is going to be benefiting poor people, or a perception, or really a wrong one, that it's going to be only benefiting people of color or Black people, and that's absolutely not true. In Mississippi, as many white people are going to benefit as Black people, if not more. But you think back to the level of the rhetoric around welfare queens in the 80s and 90s, and that this concept of people over consuming and using up these tax dollars, and these are people who don't need it. I think those kind of racist and anti-poverty ideas still persist in our government. They may not be expressed as clearly, but they're really they're holding us all back because it is hurting us economically. And I think there's a bit of this perception that it's better for something to be equal, like we all have to equally benefit from any kind of healthcare policy, as opposed to pursuing equity, which means we give those who need it what they need, so we can all achieve the level of health that allows us to be, most productive citizens. But I think certain groups and political groups really don't feel comfortable with the idea of equity. They don't feel like they want to benefit those that don't immediately benefit themselves. And then people vote against their own self-interest. I have patients myself who I'm like, they're very against expansion, but I'm like, this is you, right? Like, this is your healthcare. This is your only way into this system, because you're in a low-wage job. You're in you don't have that foot in the door to get other employer-based insurance, but because unfortunately these things are so deeply politically aligned now, and our politics is so deeply divided, that it's sad we can't look at something even like public health as something we can all agree upon. But yeah, absolutely, as a physician, it's frustrating to especially see that we profess to care about certain things, and then this is a solution that, as Dr. Roberson mentioned, is like more than throwing away money and costing lives.
Yeah, it's not only the moral aspects of providing coverage, just from a pure financial aspect. I mean, those pregnant women that you treat, if they were on Medicaid expansion instead of the traditional Medicaid program, the state would be getting coverage at 90% federal dollars, 10% state dollars instead of what they're getting now, which is a lower match than that. So that, I mean, just from that aspect, it would also be saving money in the traditional Medicaid program for the state. So there's so many aspects of Medicaid expansion that could be talked about. We could go all night on this, but Richard, getting back to you, kind of not wrapping this up, but kind of bringing it full circle. Now, your organization, Mississippi Hospital Association, is involved in an initiative process of Medicaid expansion. Can you just talk a little bit about that?
Yeah, so, we've been working on solutions for a decade with the Mississippi Hospital Association and the legislature. Actually, that process started before I came to MHA in 2015, and I'd spent a combination of about 10 years working for the state, most of which are about 15 years working for the state, about 10 years at the Division of Medicaid. And my tenure there spanned the terms of Governor Fordyce, Governor Barber, and Governor Bryant. And, as I said earlier, the issue was always stated to be, we just can't afford it. Even though we knew there was always the undercurrent of the politics of it. But the stated reason was we can't afford it. And so MHA has offered at least a half dozen options for the state over the last several years, things that have been done in other non-expansion states just to reduce the uncompensated care cost. The hospital industry has seen their uncompensated care cost almost double in 10 years, from just a little over 300 million to just a little over 600 million since 2010. And so that trajectory is just totally not sustainable for the industry. And so we've offered different solutions. I mean, if you just want to take the humanity out of it and just fix an economic problem for a healthcare industry, so the industry can then afford to just render this uncompensated care that the state evidently is going to choose to do in lieu of actual insurance coverage, then let's make sure the hospitals are able to survive in order to be there to provide that care. And so we've gone down a number of different roads with state leadership. A couple of years ago, we presented a solution that would have funded the state share through a combination of very low cost premiums for plan members and additional taxes that would be paid by the hospitals, because the math was pretty simple. If the hospitals paid $50 million in taxes to get a $250 to $300 million benefit by reducing their uncompensated care costs, it was worth it to the industry. As hard as it is for the industry to come up with $50 million, it still made sense to get out from under the massive amount of uncompensated care costs. So
I didn't want to call it Medicaid expansion.
So yeah, and so we've come up with some different solutions that were based off of the opportunities through the Affordable Care Act, but were modeled on some other things, such as what Arkansas did and what Indiana did, and tried to simplify it and improve upon what those states did, so we didn't run into the same traps. And so everything's been rejected by state leadership. We've watched across the country other red states, such as Missouri and Oklahoma and Utah, that have successfully passed ballot measures. And we've done polling in Mississippi, and the polling numbers range from 60 to 70% favorable for people that want to see Medicaid expanded to cover this low income working population. What's amazing about some of the argument is, you hear a lot about, well, these people ought to have insurance, or these people ought to, they ought to just pay for it. Well, they're low income, but they're working 2 and 3 jobs. 3 out of 4 nursing home residents in the state of Mississippi are covered by Medicaid. No one's going around telling them, you should be working. You shouldn't be on Medicaid's dime. The cost of nursing home care for Medicaid for about 20,000 Medicaid recipients in long-term care facilities is almost $900 million a year. But no one is going out calling them, unproductive citizens and, oh gosh, you ought to be working and all that. So, you know, what we're talking about are low income working adults. If mom and dad aren't healthy and they're not being able to take care of themselves, if they're not getting preventive screenings for cancer and they develop breast cancer, and mom, you know, has to go through treatment and, you know, maybe, you know, passes away, then those children's lives are dramatically affected. And the kids may have CHIP insurance, but the adults don't. And so it creates healthier families. It creates more productive workforce. It's just a no-brainer. And so when we've presented different solutions that many of the solutions pay for themselves, this actually pays for itself too. You know, you just got to wonder what really is the reason behind it. It can't be, we can't be a state that wants to promote industry, wants to promote small businesses, wants to promote family, and then say no when it comes to taking care of people's health. That just is totally hypocritical, in my opinion, and it's pitiful, and we ought to be doing better by that. And so we're supporting a coalition of people. It's a bipartisan effort because, you know, as we say a lot when I meet with legislators, about the only piece of information hospitals don't ask of their patients is, are you a Republican or are you a Democrat? We'll get just about everything else about you, but we won't get that. We don't care. And so our hospitals treat Republicans, they treat Democrats, they treat independents, they treat Green Party, Tea Party, whatever party you want to come to. So that the reality is we've got to do something on this issue. The legislature hadn't acted. So there's been a ballot initiative filed. The MHA board has voted to financially support that. We're certainly not the only ones. We're open to taking money. I think that ballot committee would probably take money from anybody, but it's basically they're taking an initiative because the legislature has not taken an initiative to get this done. And the proposal would be right now, it would stand to go on the November 2022 ballot. And that's kind of where we are with it.
Okay, we're getting close. Caroline, do we need to ask some of these audience questions or?
Hey, I'm back. There was one that came in at the end that I'd love to hear what y'all think about. That what are the cons of Medicaid expansion? So we've heard a lot about what the opportunities are of it, but what are the opportunity risks that Mississippians face as a result of expansion? Are there any?
Better healthcare. No, I'm sorry, I'm not supposed to answer that.
You know, we've looked at the pros and the cons. The pros far outweigh the cons. About the only con that you could come up with would be that the estimated cost to the state right now appears to be about $100 million to cover the expansion population. The numbers that we've seen and have been reviewed by a world-renowned economist out of Texas that also did the economic analysis back in the mid-2000s for the Republicans when they wanted tort reform. He was the star economic expert on that. We went to him to get his opinion on this. He's showing $200 million in additional dynamic state revenue coming in. So again, you're getting money from the American Rescue Plan to shore up your regular Medicaid program to the tune of $300 million for the first 2 years. That's $600 million to the good. You're going to get increased tax revenue coming back into the state through increased workforce productivity, increased sales tax spending money that comes back through the system, income taxes and all that, at a cost of $100. You know, it's kind of like the argument of, it's almost as if the state says, I'm refusing to go to work because I have to put gas in the car. There's a cost of me driving to my office every day, but the benefit far outweighs the cost. You know, I have to buy clothes, I have to go to the laundry, I have to put gas in the car to get here. There's a cost to that, but the benefit of doing my job and coming to work far outweighs the cost. And essentially what the state of Mississippi has been saying is that, you know, that they want to stay at home because they don't want to put gas in the tank. And that's bad. So when we talk about cons, You know, there's $100 million cost to it, but the benefits of it far outweigh the cost, and you're going to get all that money back and then some.
And I would say that we're not, even what we think we're saving, these are hard things to put on paper, but the costs kind of, they get shifted in other areas of the system. When a hospital has to take care of someone who has no insurance, they got to make that money back. And that's why you pay $400 for a Tylenol. That money has to get made up somewhere. So it's not just, it may not be on the government anymore. It may be on your bill. It may be on something else, some other charge, but we're not avoiding some of these charges we think we're avoiding, or saving the money we think we're avoiding, because our healthcare system is so much more expensive because we have to cover uninsured folks. And so it really is hard to kind of answer. And one of those great questions someone asked was do we see benefits of a free market system in healthcare? Healthcare is far from operates like a free market system. You can't just kind of shop around like you do a car. Ask your doctor how much something costs and watch them stare at you blankly, and then ask them to go find out and see they do not have time for it. It's very difficult. And and healthcare doesn't operate like buying a car, because if you have an emergency car crash, you just need to get in the hospital and get cared for. You are not able to shop around in that moment. And at the same time, we value markets, we still value health in some ways. So we want to give it to everybody a little bit. So it definitely doesn't, operate like that kind of typical commodity where we could lower price by competition, because of all those other hidden costs in the system, which I think really come from the fact that we have so many uninsured and underinsured folks, and it's just trying to make it up in different areas. So I think we're losing more than we're gaining, and it's short-sighted in a lot of ways, and we need to move ahead in Mississippi. We're getting exactly what we're paying for right now, which is some of the worst health in the country. And companies deciding where they want to move, I think Apple's opening up in North Carolina a new plant with 3,000 employees. What's going to make them choose to come here? And I think when we're last on everything, we're going to also be last on a lot of economic things as well. So, I'm just a physician on the panel, but I see this stuff kind of pulling up, across the board where the healthcare spills into, all other areas of our life in Mississippi.
Well, it looks like we are right at 7. So I'm going to go ahead and say thank you to all of you for participating, to Bobby for moderating and doing such a wonderful job, and including
Thanks, guys, for
Charlene and Amy and Richard in the conversation. Thank you all for being here with us tonight. And like I said earlier, if you haven't already, please like us on Facebook for all the audience members out there, and stay tuned for the second installment in this series, which we will get to on May 18th. So thank you again for participating and joining us on Facebook, and we look forward to seeing you all next month.
Thank you.
It's a pleasure.
Thanks.
Thank you.